Evet, değerli meslektaşlarım merhaba. Bu yorgun, yorucu günün son oturumunda Nobel firması tarafından desteklenen bu uydu programında beraberiz. Konumuz karışık tipte idrar kaçırma ve duloksetini olacak. E, Programa başlamadan önce bu uydu sempozyumu sırasında sizlere soracağımız interaktif 3 tane sorumuz var. Pandemi nedeniyle artık keypad kullanılmıyor. Onun için bu yöntemi size tanıtmak istiyorum. Ya bu barkodu okutabilirsiniz ya da internetten slido.com adresine girip bu şifreyi girerek soruları cevaplayabilirsiniz. Evet, ben prezentasyonu alabilir miyim? Pardon, iyice şey yapın. Özür dilerim. Bu değil prezentasyon. Sunum bu değil. Nobel firmasındaki arkadaşlar vereceklerdi kombine edilmiş sunumu arkadaşlar. Ben vakitten kaybetmemek adına bu uydu sempozyumunda birlikte olacağım Sayın Profesör Doktor Fransisco Cruz'u size tanıtmak istiyorum. Kendisini zaten çok iyi tanıyorsunuz. Francisco Cruz Porto'dan geliyor. Sağ olsun bizi kırmadı, kongremize katıldı. Benim çok uzun yıllardır tanıdığım, dostum. Her zaman birlikte olmaktan büyük keyif alıyorum bu bilimsel toplantılarda. Francisco Cruz bildiğiniz gibi Avrupa Üroloji Derneği'nin Europe Section of Functional and Female Urology'nin başında. Aynı zamanda ICS'in en önemli figürlerinden bir tanesi. Avrupa Üroloji Kılavuzlarında yer aldı ve bizimle ilgili tüm önemli dergilerinde editoryal board'unda bulunuyor. Francisco, lütfen isterseniz oturun oraya doğru ya da ben Francisco'yu buraya çağıracağım aslında konuşmasıyla ilgili olarak alabilirsek prezentasyonu. Uydu sempozyumunda konumuz biliyorsunuz duloksetin. Sempozyumun konusu da, daha doğrusu başlığı da neden kılavuzlar duloksetini karışık tip idrar kaçırmada öneriyor şeklinde. Duloksetin bu konuda aslında ruhsatlanmış tek ilaç olarak karşımızda duruyor. Yani karışık tip idrar kaçırmanın tedavisinde. Bu da önemli bir konu. Bu konuyu ilk gün ICS eğitim kursunda irdelemiştik. Daha çok cerrahi tedaviler üzerinde durduk bu kursta. Bugün şimdi duloksetin medikal tedavisi üzerinde duracağız. Bulamadıysanız şöyle yapabiliriz. Francisco Hoca'nın sunusuyla zaten başlayacağız. Demin gösterdiğiniz onun sunusuydu. Onun sunusu yürüsün. Benim sunumda vaka vardı ayrıca ona ek olarak. Onu sonra da alabiliriz. Öyle mi yapalım? Peki. Francisco lütfen. Buyurun.
Good afternoon. It's a great pleasure to be here again, and also because I was a member of the incontinence guidelines of EU during 11 years, and so we reviewed a lot of this information, and so I think it is an interesting topic to debate. But to start with, I think we can look into these statements from Alan Wynne. When we have incontinence, in theory, we can use or we can act at 3 different points. With agents that decrease the trouser overactivity, we can act with agents that increase bladder capacity by promoting relaxation. And in theory, we can act also with agents that increase outlet resistance. And that is an old statement from Alan Wynne, and I think it might be interesting to take these statements in mind, to keep them in mind for the following discussion. First, which is the size of the problem? In Europe, 40% of women in this survey said that they had a leakage in the previous 30 days. It doesn't matter the amount, but 40% is a lot. And mixed urinary incontinence was clearly the second type of incontinence, and unfortunately, one of the most difficult forms to treat. It's not particularly, by the way, also is a problem that is going to increase in the next years with the aging of the population, at least in Europe, because mixed urinary incontinence will be predominant in elderly patients, in elderly women, in contrast with stress urinary incontinence, the predominant stress urinary incontinence, which has a higher prevalence in middle age. So clearly, mixed urinary incontinence is a problem in Europe, but is also a problem here in Turkey. And I found 2 studies, one from Eastern Turkey, and if you look to the green bars, the prevalence of, in this study, the prevalence of mixed urinary incontinence above the age of 50 is around 14 to 15%, and probably will increase if the women elderly or above 50 are separated in different groups. But also from Western Turkey, one can see exactly the same figures, and mixed urinary incontinence above the age of 50 will be around 15%. So it's really a problem we have to face. We have discussed that the recommendations from EU guidelines yesterday. And the one that receives the first recommendation, which is very weak, but is just a matter of common sense, is to treat most bothersome symptom in first place. And probably we could also say start the treatment with less invasive treatments. Clearly, the guidelines strongly recommend surgery, but they recommend surgery with a lot of advertisements to women saying that the surgery will be less successful, and even after surgery, women might need additional treatments in order to become continent. And the other option is the medical treatment. And when we see the recommendations for medical treatment, we see strong recommendations for anticholinergic or for beta-3 agents, which of course only will treat urgency urinary incontinence. And we see a weak recommendation for Duloksetini. If, with a lot of additional comments, if women failed conservative treatment and do not want invasive treatment, which, as we saw before, does not treat completely the situation. So I think this weak recommendation is probably more a matter of lack of scientific information, which is really a problem when we talk about mixed urinary incontinence. So Duloksetini is a dual serotonin norepinephrine reuptake inhibitor. Acts centrally, and so is going to increase the amount of serotonin and the norepinephrine in the sacrospinal cord. That will increase the stimulation of the motor neurons in the on-off nucleus that goes through the pudendal nerve into the external urethral sphincter and will increase the activity of the external urethral sphincter. But there is also another effect that is less discussed, less debated, which is a decrease in the activity of the parasympathetic nerves going through the pelvic nerve into the bladder. So, in fact, the excess of noradrenaline and serotonin in sacrospinal cord will increase the activity of motor neurons and will decrease the activity of the parasympathetic nerves going to the bladder. And actually, this is not new. In 1995, Karl Thor published this study. So if you look to the A experiment, is the infusion of saline, nothing surprise. There is no surprise at all. But then in B, he injected, he injected acetic acid. It's not very easy to handle this. Injected acetic acid, and what you see is that in the bladder there are more contractions and also there is more activity in the external sphincter. And then he gave Duloksetini to the animals, and the activity of the external sphincter increased substantially. So you see the black bars now very close to one another, and the bladder activity returned to normal. Actually, he also verified here that the increase in bladder capacity induced by Duloksetini in this acetic acid model or the frequency of contractions that were decreased by Duloksetini or the activity of the external urethral sphincter was mediated by 5H2 receptors. 5-HT2 receptors, to be more precise. And in the same study, it was also verified that Duloksetini had a dose-related effect. So bladder capacity would increase with dose, and up to a certain level, the activity of the external urethral sphincter would also increase with an increase in the dose. So this was 95. But unfortunately at that time, nobody cared about this data, and everybody looked into stress urinary incontinence. So we had to wait until 2005, when the first study, a randomized clinical trial comparing 40 milligrams of Duloksetini twice a day against placebo, and in patients with mixed urinary incontinence, showed that the PGI responders had a better score when exposed to duloxetine than when exposed to placebo. And so at that time, the situation remained like that. Nobody, again, cared very much about this result. And so 3 years went by until another randomized clinical trial, the same dose of duloxetine, again, so the one placebo arm and 40 milligrams of duloxetine twice a day, were compared, in this case, with the number of incontinence episodes per week, and separating the patients, those with predominant stress urinary incontinence and those with mixed urinary incontinence on the right. And one can see a substantial decrease in the number of episodes of mixed urinary incontinence with duloxetine. And, going to the PGI-I, so to what the women reported about their condition, very much better or much better was reported by almost 50% of women after 8 weeks of treatment. And in terms of quality of life, there was a meaningful improvement because the minimum important difference in this quality of life questionnaire is 11 points. And so it was above the 11 points, the improvement. A few more years and another study from Bent and co-workers comparing placebo with duloxetine for the treatment of mixed urinary incontinence. This was already a large randomized clinical trial, and at baseline, the number of incontinence episodes per week were subdivided according to the electronic diary into stress episodes and urgency episodes. And these patients, these women had in average 15 episodes of urinary incontinence per week, more or less divided equally by stress and urgency. Probably slightly more stress, but it was quite well balanced. And these are the results. The episodes of stress urinary incontinence on the left were more reduced by duloxetine than by placebo, and the episodes of urgency urinary incontinence were also more reduced with duloxetine than with placebo. So duloxetine was able to tackle the two types of episodes these women had, those stress episodes and the mixed episodes. Also, in terms of quality of life, the quality of life was improved. And if you look again to the PGI-I score, those women that who referred that they were better or very much better is around 40%, slightly above 40%. So, indicating that some improvement in quality of life was obtained with duloxetine. Is it useful to combine duloxetine with pelvic floor muscle training? Because in guidelines, the conservative treatment, pelvic floor muscle training, is one of the first line of treatments for stress urinary incontinence, and probably should also be for mixed urinary incontinence, at least for the stress component of the mixed urinary incontinence. We don't have one study with mixed urinary incontinence women, but we have with stress urinary incontinence, and probably we can extrapolate the results. If you look for the first graphic on your left side, Duloksetini is superior to pelvic floor muscle training in decreasing the number of episodes of incontinence per week. And the combination did not had any effect on the decrease on the number of episodes of urinary incontinence per week. However, looking into the quality of life, and always quality of life is important in functional urology, whatever the method of analysis, intention to treat analysis or per protocol, the combination of Duloksetini with pelvic floor muscle training offered a superior improvement in quality of life. Which means that probably it might be a good sense. Unfortunately, there is no study. We need to have that study for sure. That it is very possible that women with mixed urinary incontinence might benefit of a combination of pelvic floor muscle training with Duloksetini. Duloksetini is not free of adverse events. And if we have dry mouth and fatigue, which are probably more easy to deal with, or constipation, there are adverse events like dizziness and nausea, which are more problematic for these patients. And we cannot ignore that Duloksetini might cause common and frequent adverse events, and nausea and dizziness might cause problems in patients and might reduce the adherence of this treatment. However, there are ways to reduce the incidence of adverse events, and that is written in guidelines. Start slowly. Do not offer Duloksetini immediately in the maximal dose. In this study, the beginning of the treatment was 20 milligrams twice a day, and it was compared with 40 milligrams once a day or 40 milligrams twice a day. And you can see that nausea and dizziness were substantially decreased in patients, in females who received the 20 milligram twice a day schedule or the treatment. And interestingly, in that study, women receiving 20 milligrams twice a day, in terms of number of incontinence episodes, had a reduction that was similar to those women who received 40 milligrams once or twice a day. And in terms of quality of life, you can also see that the improvement obtained with Duloksetini is similar to the one that was obtained with 40 milligrams once or twice a day. So meaning that if we want to use Duloksetini, we should start slowly in low doses. As a member of guideline panel for incontinence, we wrote very often that persistence of women on this treatment was very low. And in fact, we quoted very often this study. If I am no longer I served for 11 years, but if I had to rewrite, I am no longer a member of the panel, but if I had to rewrite, I would be more careful in my statement there, or in our statement there, because this study, women at 1 year, only 9% were on treatment. However, at every visit, women could drop out and change into a surgery, into TVT. So this is not exactly the best way to measure adherence if at every time point you can choose between two therapies. There are many factors in addition to adverse events that might be the cause of such a low adherence. In fact, if we look to the adherence of Duloksetini in the randomized clinical trials that we have available, all of them, all together, we can see that the adherence up to 30 months is, well, at 30 months is probably 25%. We might say, well, it's low. Well, if we look to the adherence of the drugs we use for OEB, in the lower part are all the anticholinergics, and the first line in the bottom is for mirabegron in UK. One can see that the adherence of anticholinergics is probably lower than Duloksetini, and we are still using anticholinergic drugs. And mirabegron is not very much above. So, in conclusions, the data support the efficacy of Duloksetini for the treatment of women with mixed urinary incontinence, and the data indicated that Duloksetini is able to reduce both the urgency and the stress components of mixed urinary incontinence. So eventually serotonin might be a preferred option when the pharmacological treatment is the preferred treatment for our particular patient that we have in front of us. Eventually, the combination with pelvic floor muscle training might enhance the clinical effect, and definitely we should start Duloksetini by a low dose in order to decrease the appearance of most severe adverse side effects like nausea and dizziness. Thank you very much for your attention.
Francisco, çok teşekkür ederiz bu güzel toparlama için. Karşımıza çıkan idrar kaçıran kadınların 1/3'inde karışık idrar kaçırmayı gözlemliyoruz. Ve Duloksetin bu karışık idrar kaçırmanın her iki komponentine de etkili olan elimizdeki tek farmakolojik ajan. Kılavuzda belirttiği gibi uzun dönem ilaç bırakma oranlarının yan etkilere göre fazla olduğu söylemi aslında belki bir yanlış değerlendirmeden kaynaklanıyor olabilir. Çünkü Francisco'nun da gösterdiği gibi çalışmalarda aslında antimuskariniklerden daha farklı bir ilaç bırakma durumu yok eğer doz titrasyonu yaparak başlarsanız. Doz titrasyonu yapmak önemli. Gastrointestinal yan etkileri biliyorsunuz en sık olarak görüyoruz. O etkiler görülse de geçici oluyorlar, birkaç gün içinde kayboluyorlar. Benim pratik tecrübemde bu şekilde ilerliyor. Dolayısıyla cerrahi tedavinin özellikle uygun olmadığı ya da hasta tarafından tercih edilmediği durumlarda bu tedaviyi bizim armamentaryumumuzda bulundurmamızda büyük fayda olduğunu düşünüyorum. Şimdi asıl sunumumuz geldi. Burada sizinle bir kısa olguyu paylaşmak istiyorum. Bu 60 yaşında bir kadın hasta karışık idrar kaçırmayla başvuruyor. Özgeçmişinde bir vajinal doğumu var. Ek cerrahisi ya da kullandığı ilacı yok. Fizik muayenede bir grade 1 sistoseli ve rektoseli var Bağdın'a göre. Yine ICS standart öksürük stres testi pozitif. Mobil üretrası var. Yani aslında bir orta üretra siringine de uygun bir hasta şu fizik muayene ile. Radyolojik ya da laboratuvar anomalisi yok. Üroflometrisi normal, rezidüel idrarı da hastanın yok. Bu hastanın ICIQ sorgulama formunda çok şiddetli idrar kaçırmadığını görüyoruz. Günde bir kez diyor ortalama, küçük miktarda diyor. Ve 10 üzerinden hayat kalitesinin günlük yaşamının ne kadar etkilendiğini de 6 olarak işaretlemiş. Ne zaman idrar kaçırıyorsunuz sorusuna da tuvalete yetişemeden de diyor, öksürmekle, hapşurmakla da diyor, hareketle de diyor. Yani hem stres hem de idrar kaçırma komponentini tarif ediyor. Şöyle bir el kaldırsak, bu ICU-IQ sorgulama formunu kaç kişi kullanıyor diye sorsam, bu kayıt dışı bir soru. Teşekkür ederim. Hepimiz kullanmıyoruz gördüğüm kadarıyla, azınlıkta kullananlar. Mesane günlüğü yapılmış bu hastaya, yapmışız. İçtiği içecekler açısından bir anormallik yok. Çok az kahve ve çay tüketiyor. 350 mililitre maksimum hacimleri var. Ortalama 200 mililitreler işemiş hep. Günlük sıklığı 6-8, gece idrar kalkması 2. Günde bir iki kez ani sıkışma ama her zaman ıslak değil. Bazen ya da seyrek ıslak. Ama idrar kaçırmayı stres olarak özellikle kuvvetli egzersizle ve öksürükle yaşıyor ve egzersiz yapıyor bu hasta. Günde ama diyor ortalama diyor ben diyor bir pet değiştiriyorum diyor idrar kaçırma için. Böyle bir hasta. Şimdi ilk sorumuz, bilmiyorum bu şeyi yapabildik mi? Konuşmanın başında size gösterdiğim barkod ya da web sayfasını. 2 şıklı bir soru bu. Bu hastada şu aşamada bir ürodinamik çalışmaya başvurur musunuz? Basınç akım çalışması veya sistometri. Yoksa önce ben bir konservatif bir medikal tedavim mi denerim, ondan sonra başarısız olursa mı yaparım diyorsunuz? Cevaplarınızı rica edelim. Ne zaman tamamlayalım? Oldu herhalde. Oldu mu? Evet, çoğunluk, evet, hala oylamalar devam ediyor. Biraz bekleyelim. Evet, çoğunluk, sonuç şey geliyor mu buraya bize şimdi? Ben önce konservatif ya da medikal tedavimi denerim şeklinde cevap verdi. Ben Profesör Cruz'a sormak istiyorum. Acaba sizin yanıtınız ne olurdu bu soruya?
Well, definitely, I would vote with the majority of the colleagues in the audience. There is a general recommendation for urodynamics in guidelines that it should not be used in first line if we are going to use conservative treatment or medical treatment. And because we can always stop the medication and go into another more invasive procedure, I don't think we need to initiate Duloksetin or other medical treatment to have the cystomatogram and pressure flow studies. Are invasive. More important definitely is the bladder diary and to understand how many cases of urgency incontinence and stress incontinence occurred during 3 days or during 7 days.
Çok teşekkür ederim. Ama aslında bu sorunun bir tane doğru cevabı yok. Ürodinamik çalışma yaparım diyenler de bence haklı ve kimse de onlara niye bunu yaptın dememeli. Tamamen çalıştığınız sistemle de ilgili ama bunu yapmadan da konservatif tedavi, medikal tedavi elbette uygulayabilirsiniz. İkinci sorumuz, peki o zaman tedavimizi konuşalım. Öncelikle pelvik taban kas çalışmalarıyla birlikte medikal tedaviyi uygularım diyenler ki medikal tedavide elimizde olan bütün ajanları ben oraya ekledim. Ya da ben direkt cerrahi yaparım, stres idrar kaçırıyor bu hasta, stres testi de pozitif diyenler herhangi bir ürodinamik çalışma yapmadan ya da ben direkt medikal tedaviyle, konservatif işlerle uğraşmam pelvik taban çalışmalarıyla. Ben ürodinamimi yaparım, ürodinamik stres idrar kaçırmayı gösteririm, ondan sonra da ameliyatımı yaparım diyenler bu hastada. Bu arada biliyorsunuz genel yaklaşımımız hep hangi tür idrar kaçırma tipi baskınsa onun üzerine gitmek ama bu hastada ve bazı hastalarda olduğu gibi her zaman bunu net yakalayamayabiliyorsunuz. Bu hastada bize o bakımdan çok büyük ipucu vermiyor. Evet. Tekrar Profesör Cruz'a sormak istiyorum. Bu soruya sizin yanıtınız ne olurdu?
Certainly the answer number one. I would offer pelvic floor muscle training because it has a clear effect on the stress urinary incontinence component. It might also have some effect on urgency urinary incontinence component. It is a non-invasive method. It might be bothersome for the patient requiring to go to the clinic on regular intervals, and many women don't like that. But nowadays, with our experience with the internet, many women can do the exercises at home once they were taught in the clinic. And that was tried in Norway, because in winter it's not easy to travel in Norway, and it works very well. So I think we can do pelvic floor muscle training, and probably in order to decrease the necessity of traveling of our patients, eventually to initiate it by internet. Of course, it might be combined from the very beginning with medical treatment, or we might introduce these treatments step by step, introducing first pelvic floor muscle training. Eventually, I don't remember the body mass index. Eventually, I don't know if it was necessary to have some reduction in weight, some adjustment in fluids and in caffeine, and probably we could call her back within 3 months and see what was the effect of pelvic floor muscle training alone. We could discuss that with the patient. I think both options were correct.
Evet, çok teşekkür ederim Profesör Cruz. Hem yüksek vücut kitle endeksi hem de bu hastada olmayan üretranın immobilitesi bizi aslında cerrahiden uzaklaştıran faktörler ve bunlara da mutlaka dikkat etmemiz lazım. Şimdi hemen son sorumuza geçelim. Peki ilk şıkta anlaştık, çoğunluk ilk şıkkı söyledi. Peki bu şıktaki tercihlerimiz hakkında ne düşünürsünüz? Sadece pelvik taban egzersizleri mi bu hastaya önerirsiniz? Yoksa pelvik taban egzersizlerini duloksetinle mi birleştirirsiniz? Ya da bir antimuskarinikle mi birleştirirsiniz? Ya da bir beta 3 agonistle mi birleştirirsiniz? Evet, %83 oranında pelvik taban egzersizleri duloksetinle birleştirildi. Diğer moleküllerden yani antimuskarinikle beta 3 agonistle ne farkı var duloksetinin? Stres idrar kaçırma komponenti üzerindeki etkisi, ama diğer moleküllerde bu etki yok. Profesör Cruz, sizin bu soruya yanıtınız ne olurdu?
Well, Duloksetini is not available in all countries. In my country, in Portugal, it is not available. So I could not offer this to my patient. But if I had it available, I certainly would offer her Duloksetini in 20 milligrams twice a day, very, very slow doses and starting to increase. After explaining her that if adverse events would come, well, we could always stop the medication and replace for antimuscarinics or beta-3. But of course, with antimuscarinics or beta-3, particularly with beta-3, we don't have adverse events or very few adverse events, with the exception of, well, having to measure blood pressure. But we are not going to tackle the stress urinary incontinence episodes of, and so it has some advantage. So clearly, I think For the countries where Duloksetini is available, it is an excellent option to start for mixed urinary incontinence.
Teşekkür ederim. Profesör Cruz herhalde bu cümleyle, slayda yansıtalım lütfen. Bu cümleyle aynı fikirde. Benim de görüşüm bu şekilde. Özellikle cerrahiye uygun olmayan, stres inkontinans temelinde konuşuyorum. Cerrahiye uygun olmayan, cerrahiden düşük başarı beklediğimiz ya da cerrahi istemeyen hasta grubunun yanında sıkışma tipi idrar kaçırma ile birlikte stres idrar kaçırma birlikte olan karışık idrar kaçıran hasta grubunda da duloksetin önemli bir seçenek olarak karşımızda duruyor. Şimdi izninizle sözü sizlere vermek istiyorum. Sorularınız varsa Cüneyt Hocam buyurun lütfen.
Bu stres predominant mixed inkontinansı değil mi hocam olduğunuz?
Yok, ikisi birlikte aşağı yukarı. O konuda bir predominans hasta söylemiyor.
Peki. Ne kadar süre sonra bu başarısız deyip cerrahiye karar vermeli? Ne kadar beklemeli? Birinci sorun bu. O kararı verirken ürodinami testi yapılmalı mı?
Teşekkür ederim Sayın Hocam. Profesör Cruz.
Well, that is an excellent question. It depends first on the success of the treatment. If the patient is happy with the treatment or whatever the treatment we are offering, conservative treatment, if she's happy, I would keep the medical treatment because we know that with surgical treatment, and she is 60 years old, with surgical treatment, we are not going to cure all the patients. And mixed urinary incontinence will cure probably no more than 60% of the patients. So that is important for our patients to understand that if they jump into the surgery, they might end up with still urgency urinary incontinence episodes first, and so they will require antimuscarinics or beta-3 agonists. And they also need to understand that the surgical treatment with a midi-urethral sling, for example, is not effective forever. There is a decrease with time, and if we define, I always like the Thomas trial definition because it was the first that had the courage to say, no, incontinence is no leakage in no additional surgery for whatever the reason. And at 5 years of follow-up, the midi-urethral slings with this definition only had cured 50% of women. So 50% had some kind of recurrence or some kind of complication. So women need to understand that offering surgery, we are not offering a miracle. We are offering an effective treatment, but with time might be lost. And so she is 60. Why not to try a medical treatment first? I think it is the logical step. And then explaining everything to the patient, and I think this is the most important thing, explaining to the patient the steps that can be ahead, eventually to decide in the future if she really needs or not surgery. But that is something that might be decided later on because it is not a severe case. She is bothered, but it is not a very severe case, if I understood. It's probably one episode per day. So I think one can wait a little bit before going into very invasive treatments.
Evet, tamamen katılıyorum Profesör Cruz'a. Oktay Hocam buyurun lütfen.
Tedavide tam istediğimiz başarıyı elde edemedik ve hasta cerrahi istemiyor. Bu durumda bir medikal tedavi kombinasyonu düşünür müsünüz?
Evet, mesela stres komponentinde bir azalma oldu ama
Evet,
ölç
sıkışma
komponentinde
devam
bir sıkışma devam ediyor. Hocamın sorusu net olarak duloksetinle bir antimuskarinik ya da beta-3 agonistini kombine eder misiniz şeklinde. Doğru anladım değil mi hocam? Profesör Cruz.
That is a difficult question. I don't have scientific evidence of combination. I don't see any problem in combining. I would not definitely combine duloxetine with antimuscarinic drugs because of the antimuscarinic effect of duloxetine, which is the cause of dry mouth and constipation. So I would try a combination of duloxetine with beta-3, definitely. Being careful, and it is an off-label combination, so one has to be careful about adverse events, and so I think this patient had to be monitored very closely.
Evet. Ömer hocam, soru mu? Gidiyoruz. Başka sorusu olan var mı? Yok. Peki değerli meslektaşlarım, süremizi tamamladık. Ben kıymetli Profesör Cruz'a çok teşekkür ediyorum. Bu muhteşem bize katkısı için, hem kongremiz için hem bu uydu için. Belki bu uydunun özetini de şöyle yapabiliriz eve götürülecek mesajları. İdrar kaçıran kadında değerlendirme çok önemli. Ve bu değerlendirmede de hastanın beklentilerinin analizi, gerçekten ne istediğini anlamamız tedaviyi planlarken şart. Bu seçenekler ne kadar artarsa tedavi seçeneklerimiz bizim elimizde o kadar kuvvetleniyor. Hastalarımıza sunacağımız seçenekler de artıyor. Duloksetin seçeneğinde eve götüreceğimiz mesaj başlarken mutlaka doz titrasyonu yaparak başlayın olmalı. Ve bununla birlikte duloksetinin uzun dönemde elbette ilaç bırakma oranları var ama bunların bizim kullandığımız diğer moleküllerden çok farklı olmadığını da biliyoruz. Ben sabrınız için çok teşekkür ediyorum. Profesör Cruz, sizin eklemek istediğiniz herhangi bir şey var mı eve götürülecek mesaj olarak?
Probably I would like to tell you a story why things sometimes go into a certain direction in the area of pharmacotherapy. It was very strange for me why industry, Lilly at that time, having a drug that in animal models was quite effective for both for acting on the sphincter and on the bladder, they decided to go into stress urinary incontinence because at that time mixed urinary incontinence was something very vague. And they probably were too much greedy and they did the wrong move. And eventually we lost during several years one drug that if had been well investigated at that time could have been very much useful for the treatment of many women. And so I think we have to be careful about not running very quickly into some more obvious indications and trying to use the drugs in the right way and for the indications they might be useful.
Çok teşekkür ederim. Sizlere de sabrınız için teşekkür ediyorum.